What if you could take that risk, make that change, reach that goal, live your best life? Welcome to another episode of the What If You Could podcast, where we get together with amazing experts and everyday people who share challenges, encourage healing, and explore the possibilities that life has to offer. I'm your host, Gary Scott, and I'm excited that you're along for the ride. Hey, everybody. Welcome to another episode of the What If You Could podcast. And today, my guest is David Jeter. Hey, David Jeter.
Nice to be here.
Yeah, right on. We're going to have some fun. I'm going to fire off David's bio real quick so you know who we're playing with. And then I'm going to shut up and we'll just talk to David. Um, David Jeter. Dave is a physical therapist of 23 years who owns Acceleration Physical Therapy in Spokane, Washington. He specializes in orthopedic care with the use of manual therapy and functional exercise, allowing the body to load more effectively by resolving movement dysfunction and increasing strength is the definition of musculoskeletal health. Dave, I'm sure there's at least four different things on there I completely trashed because I can't read or speak.
I think you
I'm
did
not that
great. I think you
smart,
did
so
great.
you can correct me anytime you want on any of those things I said. But welcome, Mr. David Jeter.
Yeah, thank you very much for having me.
Hey, so since we are the What If You Could podcast, I do ask one question to start off with, and I always ask people, based on your life or your history or what you do, did you ever have a what if you could moment or what if you could that you'd like to share with us?
My what if I could? What if I was in charge of the world, sort of thing?
Yeah.
I would have everyone who has musculoskeletal pain to start with physical therapy, and wherever their journey ends up, it ends up. But everyone should start with getting the body moving and working properly first to see what happens, and then if other more invasive techniques and procedures are necessary, then that's totally fine. But hopefully, by getting the body moving better, loading better, stronger, balance, coordination, that sort of thing, the natural healing capacity of the body can take over, and all of those more invasive procedures are not necessary.
What's the difference between chirotherapy and physical therapy?
Chiropractic and physical therapy. Um, let's let's say this. I think that the the perceived turf war between physical therapists and chiropractors is very
Wait
much
a minute.
over very much
There's
overblown.
a turf war?
No, there's just a lot of people who are like, oh, I would never go to a chiropractor, and there's
I'm
all
that guy.
these yeah, there's all these different things where people say, oh, I should do this, or they shouldn't do that and whatnot. And I think most of it's just kind of malarkey. And when I think of what chiropractors are doing, most of what I feel like they're doing is really good stuff. And most of what physical therapists are doing is really good stuff. And if we could collaborate more, and if we could work together more effectively and efficiently, then I think a lot more people would be helped rather than it's kind of one of the things. We have a lot more in common than we have arguments about, and we can always find some little things to argue about. But then when we look at the whole system of medicine for musculoskeletal care, I think both physical therapists and chiropractors would agree that our philosophies are much closer to allowing the body to heal itself naturally by getting it moving properly, rather than trying to go in and do something more invasive.
Do do is it abnormal or not the norm for a chiropractic office to have a physical therapist in it or
It
and vice versa?
Almost never. You would not see, especially in Washington State, at least. I don't know in other places. I'm not saying that I don't work closely with chiropractors, but in chiropractic offices, you would not almost ever see a physical therapist. A lot of times you would have a massage therapist, and in a physical therapy office, you would not have a chiropractor. And part of the reason why is because chiropractors can't employ physical therapists, and physical therapists can't employ chiropractors. That's just state law kind of things. So it's again, there's these turf battle kind of issues, which are somewhat silly and mostly historical.
We have too many state laws, but I'm not going to get into that. So see, I'm deathly afraid of chiropractors. Now
Okay.
I've been to them, and
Hmm.
my son and my daughter-in-law go religiously. I think they
Uh-huh.
go every week. They even have their baby going at like 3 months old, and now the baby's 2 years old, and stuff like that. But when I went out shooting out in the desert with my kids, and I fell off a mountain and trashed my shoulder, I went to a physical therapist.
Okay.
I didn't think of going to a chiropractor and maybe having it popped back in. And so that kind of got interesting on the different things we went into on that. So I guess if a chiropractor adjusts you, a physical therapist does what?
We do mobilization. We do joint mobilization. I do joint mobilization because I'm a manual therapist,
Mhm.
and we are taught to do manual therapy from a joint perspective and a soft tissue perspective. What's interesting about what people would call an adjustment or a mobilization or a manipulation is that that is one of the oldest techniques known to man. I mean, if you can think about what could humans have figured out about medicine early on in our existence, mobilization is a pretty easy one because you can kind of you move your body in a certain way and it kind of clicks, and you kind of like maybe you push on your friend and it pops and they're like, oh, hey, that feels good. You're going to figure that out. Like humans are going to figure that out. And so there's documentation of manipulation in Aristotle's time and Plato's time, that sort of thing. So the idea, what's interesting to me is when I do joint mobilization and whatnot, I have a lot of times where people are like, oh, this is similar to what the chiropractor does to me. And I was like, it's always interesting to have that conversation because chiropractic was kind of made up around the 40s or 50s. So we're only talking about a profession that's been around for 75 to 100 years. And you're
Wow.
talking about a technique that's been around for thousands of years. Osteopaths do it, naturopaths do it, physical therapists do it, acupuncturists do it. Everybody has a certain brand of technique that they do that mobilizes joints. But chiropractors have just done a fantastic job at branding themselves as the people who do it most and best.
I'm not going to walk in your office and you're going to grab my head and spin my neck around, right?
Well, again, I would always obviously discuss with you why I'm doing what I'm doing and how I'm doing what I'm doing. But there are always going to be techniques that are more gentle, and some of them are more aggressive, and some patients require techniques that are super gentle. If you have a 80-year-old osteoporotic woman, you're probably not going to do a high velocity technique. But if you have a college athlete that has a joint that's pretty stiff and you're not able to get it moving by doing some wiggling and whatnot, then maybe a high velocity technique is warranted in that particular case. But again, you would talk to the patient and make sure that they are informed about what you're going to do and why you're going to do it and how you're going to do it, such that they feel comfortable that they're going to choose to say yes, that I want this procedure done to me. And I think that's an important distinction. And I mean, informed consent is always an interesting
It's a good idea to ask
well,
somebody
but
to spin their head around.
it's also just a myth in general, right? I mean,
Right.
the idea that you go to your doctor's office, especially you go to the hospital, and you have informed consent about every procedure that's ever going to happen to you and all the risks associated with those things. Nobody understands what those possible risks are, especially in an emergency situation, or what drugs are you giving me right now? Well, you have no idea what
I don't
they're
even
giving
give a
you.
shit. Just I'm
Right.
in pain.
Yeah, but are there side effects to those
Right.
drugs?
I
I
know.
mean, but are you actually informed about those risks and whatnot? But again, that's sort of a different that's sort of a different topic.
But you guys do adjustments. I mean,
No, we
you
don't do adjustments. We do mobilization, right? We do
mobilization. So
joint
what
mobilization.
is a mobilization?
So, so the joints move on each other, right? So when you're let's go for an easy example. My finger. If I bend my finger, one bone is moving on the other bone. It's sliding on the other bone. Okay. So I can take one of these bones and I can wiggle it between, on the other bone. I can pull it apart to do traction. I can slide it at a 90-degree angle from the joint line and do a version of joint mobilization. So if I have a stiff finger and it won't extend fully, if it won't straighten out fully, I can take it and I can wiggle it in a way where that joint will free up and it will give me full extension. Now you can take that into the spine. You can take that into any of the other peripheral joints. That we work with. It's very common for someone who has an ankle fracture, for instance. So if you fracture your ankle and they go in there and they put a plate in there because you fractured it pretty bad, and then you've been in a boot for 6 to 8 weeks and you haven't moved it at all. When you come out of that boot, you're going to be incredibly stiff. So it's very important for a qualified physical therapist to get in there and move all of those joints around that healed fracture, right? Obviously, the fracture is healed at that point, and get that foot moving and the ankle moving, and there's 26 bones in the foot. And so all of those joints have to move properly for the person to walk properly. And if you leave that person with a stiff ankle or a couple of foot joints that don't move well, that is the kind of thing that creates problems down the road. That's biomechanical dysfunction that is going to create a problem. Maybe if their ankle doesn't fully dorsiflex or pull back, right? If you can't pull your toes towards your nose properly when you walk, then you can't get your leg behind you. I know that's sort of an interesting thing to be thinking about, right? But if you take a step with your right foot and your left leg has to go behind you, then that ankle has to bend. And if it doesn't bend properly because you fractured the ankle and no one ever got that ankle moving properly, then all of a sudden that lack of movement at your ankle is going to go and ask your hip to do something funky and weird. Right. And that hip is going to start maybe barking and saying, hey, I'm not really happy with this situation because ankle isn't doing the job that it's supposed to. So that's how physical therapists think. When someone comes in with a hip pain problem, right? So let's say they come in with tendonitis or bursitis of their hip. We're going to be looking at everything from their probably mid lower back down through the rest of their leg to see what is working and what is not working, because that hip bursitis or tendonitis is a result of the problem, not the problem, right? So the pain. So again, this sort of gets into our philosophy of if there's a soft tissue that is painful or irritated, that is not necessarily something that you should be beating up or stretching out or trying to strengthen. That might be something that is being beaten up by another structure that isn't moving properly or isn't loading properly. So our job as physical therapists is to resolve the biomechanical dysfunction throughout that whole system, to get that system working properly, get that ankle moving properly so that the hip doesn't have an abnormal load on it during walking, and that soft tissue gets irritated.
I think everyone can relate to that. I mean, if you've got a hitch in your giddy up, next thing you know, your back hurts, your hip hurts, your neck hurts, your shoulder hurts. You know what I mean? You're out of alignment and you're not functioning properly. You might have some pinched nerves, you might have all sorts of shit going on. What do you think of when I fell off that mountain and just busted all sorts of stuff up? Um, what do you think about cortisone shots? I mean, are you
Yeah.
for that, against that? What's the deal? Because I
I
didn't want one. I was pretty adamant to not get one, and I got one, and I wish I had.
Well, let me start here. Let's talk about what a cortisone injection is.
Okay.
Um, I think of a cortisone injection as a fire extinguisher, right?
A
So if
what?
you a fire extinguisher.
A fire extinguisher. Okay.
Okay. So if you have a fire in your house, your wall is just on fire, right? The first thing that you want to do, obviously, is put that fire out, right? And so it's totally fine to use a fire extinguisher to put that fire out. It's appropriate to do that. But there's the next thing that you should do is you should figure out, why did that fire start in the first place, right? I mean, that should be your thought process, right? Not
Right.
just, okay, I put the fire out, now I'm just going to go walk away
Well,
and
that's what the
see if
fire
it comes
department would do,
back.
right? They'd have the fire inspector come in and say, "How the hell did this catch on fire?" Right? They would
Exactly.
investigate the source of the fire.
But see, unfortunately, what I see is that people go and they have a shoulder that's painful and they say, okay, I'm going to put that fire out. I'm going to put that inflammation out with a cortisone injection. But then they don't do anything about the reason why that shoulder became painful in the first place, right? They're not peeling back the onion to try to if decide what is the original sin here. And that therein lies the rub, right? If you just keep getting this, the story that I hear from people is my shoulder hurt. And so I went to my doc. They gave me a cortisone injection. It was great for 6 months. And so I got another cortisone injection. It was great for 3 months. And I got another cortisone injection. It was great for a month. And then this last time, it didn't work at all. And now I'm at physical therapy. And it's like, okay, well, if you had started with physical therapy, we could have gotten your neck moving and your upper back moving and your shoulder blade moving and your collarbone moving and the shoulder joint itself moving properly such that there wasn't stress on that structure that was painful, and it could calm down and heal up. And then we could have progressively strengthened and loaded that whole system such that it could tolerate different loads, which is again is what we do. Now, there's plenty of times where people come in and their shoulders really fired up, and we do all the things that we do to get everything moving, and it doesn't calm that structure down fully. Well, that's the time where you go in and you do that cortisone injection, right? If you've gotten everything moving and it hasn't calmed down, then you have that cortisone injection, boom, it calms it down. Then all of a sudden we can move on to the next phase of what we want to do in terms of loading. So I like to think of cortisone injections as a great way to, it's a means to an end, right? It can temporarily calm some things down so that we can make some other gains in other places of our physical therapy practice. Because again, it's kind of like if you were like, man, I'm really tired every day. I think I'm just going to take just a little bit of methamphetamine, in the morning. Just
Which
like
I do.
just a tiny bit. I mean, just I'm not a lot, but just a little bit
I'm
every,
microdosing. I'm
yeah. I mean, just
microdosing meth.
that's the kind of, I mean, again, maybe that's a little bit hyperbole to compare cortisone with methamphetamine, but it's just not
I
a very
get your
good
point,
it's not a
though.
very good long-term strategy, I guess is what I'm saying. It's not a good long-term strategy.
No, but I totally get your point on that. What about I'm gonna hack this name, so I'm just gonna try the initials. What about PRP?
PRP. Okay, so again, I think there's uh, some really, really, really interesting things about PRP. So if you have a structure that is damaged for whatever reason, and you want to go and you want to take some stem cells, a lot of times they're taking the stem cells out of the pelvis, out of the bone marrow in the pelvis, and they are creating this sort of goo of stem cells that they can inject into that structure that is problematic, and those stem cells can help to regenerate things and whatnot. Well, again, that is an interesting strategy to try to regenerate a structure. And if that structure lives in a neighborhood that is moving well and is loading well, that's probably going to work pretty well. But let's say, for instance, you have a shoulder that's very painful, a rotator cuff that you want to do PRP on, but then all of a sudden your neck and your thoracic spine are in this really stiff posture, like you have in that sitting posture where you have your head forward and your shoulders are slumped forward and whatnot. Well, every time you try to raise your arm up overhead in that slumped posture, you're beating the snot out of that rotator cuff. So if you don't release and resolve the biomechanical dysfunction that is your thoracic spine and your lower neck and your ribs and the scapulothoracic joint and how the collarbone is moving at the AC and SC joints, if you don't get all of that moving properly, then you're just hammering on that structure that honestly will never heal. But if, again, similar to the cortisone injection example, if you get all of that moving well and you want to shoot some PRP in there and try to help some of the healing properties of that structure, I think that's a fantastic idea. But it should be done in the context of a whole either upper quarter that is moving and loading properly.
Now, when were chatting a little bit before we started, you had mentioned, the reason you come on these podcasts, you're not hawking a book, you're not hawking a program. We're gonna touch about, food and beer because, food and beer is important.
It is.
But you said, I do this because I mean, there's a lot of misconception about this. Physical therapy is super important, and I just kind of, I don't know if you said set the record straight, but I mean, you wanted to kind of let people know about the importance of the physical therapy, and you're not doing it because you're hawking something. You do it because you really give a shit.
Yeah, I mean, honestly, physical therapists are just about as bad as any profession out there at telling people what exactly it is that we do. Most people have a perception that we are a combination of personal trainers and massage therapists. That's kind of what people think of. And I feel like uh, I feel like we've done ourselves a really significant disservice by not making sure that people understand that when they get injured, we are the best place to go first. And we don't need a bunch of imaging and whatnot to rule out or rule in major pathology. So a lot of times these days, people are coming to my office and there's some newer rules related to insurance companies that are saying that you need to have 6 visits of physical therapy before you can get your image or your injection or something like that. And so uh,
Wow, that's kind of huge.
so physicians are doing us a little bit of a disservice, in their language, by saying, well, you need this image, but you have to go to physical therapy before you can get this image. And so go to physical therapy, and then once you're done with 6 visits, then when you get your MRI, and then we can quote unquote find out what's going on. So there's a lot of problems with that mindset, but the biggest problem is that people feel like, okay, this isn't going to help. This isn't going to be a valuable thing for me. I'm just doing it so that I can get this image, and the image is going to somehow tell us information that is going to direct treatment. Well, the reality of that situation is the vast majority of people do not need surgical intervention for their low back pain, for instance, right? Unless you have specific things going on that is surgical in nature, it's pretty unhelpful to have an MRI to show degenerative changes. So I don't know you well, but you appear not to be 20 years old.
I am 61 hard worn, driven hard and put away wet years old.
So
I'm 61.
I promise you, if you had an MRI right now, you would have degenerative changes and disc bulges in your lumbar spine.
I've
I,
had multiple MRIs because I have cancer. I had cancer, so they scan the shit out of me. Yeah.
okay.
I'm sure they
So
found all sorts of stuff.
but pain, no pain, regardless of any amount of pain that you have, no pain, pain, you're that is going to be that is going to show up on that MRI, right? So in healthy subjects of your age group who don't have low back pain, when they MRI them, more than something like 70 or 80% in your age group would have those findings. So when someone comes into my office and says, okay, I have this MRI that shows these findings, that doesn't mean anything to me, right? None of that is terribly important because they aren't showing things that are leading us down the road towards the necessity for further treatment, right? And again, if people aren't moving well, then it doesn't matter anyway. So again, I'll give you an example. Let's say, for the sake of argument, you have this L4-5, which is very common, disc protrusion or degenerative disc disease, which again is incredibly common. But your left hip doesn't go backwards at all, right? So it doesn't go behind you. It's very, very stiff, which again, if we all sit most of the day. We're in this seated position where our hips are kind of forward. When we stand up, we can kind of get to straight, but we can't necessarily get our hips to go behind us very well. That's a very common stiffness that we see. Well, if your leg doesn't go behind you, if you have to take a step forward with your right leg and your left leg doesn't go behind you, that motion has to come from somewhere. And sometimes that motion comes from the next best thing, which is your lower lumbar spine. And so the fact that your left hip doesn't go behind you creates stress on L4-5, which is irritating it quite a bit and creating that painful mechanical pain. Now then, so what needs to happen is someone has to go in there and selectively move that left hip such that it goes behind you and it works properly to take the stress off of that low back. And if you do that, 9 times out of 10, that low back says, hey, thanks very much. It calms down. You can do all the strengthening that you need to do. And as long as you keep yourself a combination of moving well and strong, then you do well over time. But consistently we're seeing people who have this back pain and they immediately go to more invasive procedures, again, injections, discectomies, fusions, that kind of stuff, and they still have all of this stiffness. So if your left leg didn't go behind you, and that's the reason why you had L4-5 that was starting to break down. If you have an injection in L4-5, that might last for a few months. But if the hip still isn't doing its job, that's going to break down again. It's just going to become a problem. Now, let's even go down the road. Let's say you have fused L4-5, but your left hip still doesn't go behind you. Guess what happens then? All that motion just goes to the one above and below that fused segment, right? So now L3-4 is taking the beating instead of L4-5. So we can just keep going, do you want to just like selectively fuse the next one down the road? We've got to look at this as, L4-5 doesn't live on an island. It's not an isolated thing. It lives in a neighborhood, and that neighborhood needs to move properly and it needs to load properly.
So I guess you brought up so much stuff. We've had gang warfare. Now we've got good, bad neighborhoods. But I've got to go back to this insurance thing because this kind of blows my mind.
Yeah.
But you're in Washington, which is a lot like California, which means they just want to regulate everything. I mean, literally, I think they just fined me for the color of my desk. So the do insurance companies cover physical therapy?
Yes.
Okay.
They're
So
required to cover physical therapy.
Okay, that's awesome. Okay, because I fought forever to get my insurance company when I needed the physical therapy for my shoulder. However, so now though, because they don't want to do MRIs because they're expensive, so the insurance company goes to the doctor and say, "Doctor, you need to," because everything's run by the insurance company. You need to go and require your patient who's in, to go who needs an MRI to go and get six physical therapy treatments before they can get their MRI.
Correct.
And then, so it could be a shoulder, it could be a knee, it could be back, it could be an ankle, it could be hip, it could be whatever. And
Yes.
they need an MRI for this for whatever reason, a car accident, chronic pain, fell down, older people, whatever. I mean, how long will it take you to put them through 6 weeks of physical or six sessions of
It
physical
could be
therapy?
as little as 3 weeks. Most times I see people twice a week.
Okay, so
But
3 weeks.
but let's go back on this.
Okay.
I loathe almost everything about insurance companies. So
Yes, of course we do.
but
They're
they
the
tend but
devil.
they're actually right in this particular case,
Okay, well, I
right?
thought so. That's what I was trying to
And
get
so
at.
the
Is
so the
that
problem so the problem here is that um when you go to your primary care physician or you go to that urgent care and you say, hey, my shoulder hurts because I fell off a trail, all right? Instead of saying to you, taking a detailed history, looking at how that shoulder is moving, doing special tests to determine what structure is or is not involved, doing a proper physical exam, practitioners short of time, again, I'll give them a little bit of grace there. Practitioners short of time are just going straight to, well, let's just take a picture of it and see what's going on, right? But here's the other problem with that. Okay, you're not 20 years old, right? And you have some things going on with your shoulder. Let's say that I promise you have shoulder pathology, right? And in the other shoulder that wasn't injured in that particular accident. So if
Oh
you've had
yeah,
an
my
MRI,
rotator's trashed from working out and swimming and yeah, so
so
it's already I've got rotator cuff issues on the from before I fell.
sure. So so I guess my point is that lots of things can show up on images and they may not be contributing to that current problem, right? So just because it shows up on an image does not mean that it is the thing that is causing that painful tissue, number one. And number two, even if that thing is the quote unquote, it's not the problem, it is the result of the problem, right? That painful tissue is the thing that is getting beaten up. It is not necessarily the problem. The problem is the movement dysfunction and the lack of loading tolerance throughout the whole quarter, especially when we're talking about longer term, these repetitive motion injuries, right? Obviously, I'm not saying that if you fall down a cliff in your shoulder, you can't move your shoulder at all, that an X-ray isn't valid, right? That's
Yeah.
obviously make sure that things aren't fractured. And again, if you do a physical exam and it has some findings and some indications that there is something other going on where you maybe you have a weird infection going on. Maybe you have a blood clot. Maybe you have cancer. Maybe you have some sort of uh, it could be your gallbladder. You know, your gallbladder refers up into your shoulder region. So there's a whole host of different reasons why imaging can and should be done. But all too often in this day and age, you're going into a primary care and you're saying my shoulder hurts, and they're like, okay, well, let's just take an image of it. Let's just see what's going on in that shoulder without doing physical therapy first. Whereas if someone comes into me, I'll give you a totally different example. This woman who was about 45 came into my office, and she said she came in with a diagnosis of an ACL tear, right? So she tore her ACL, I don't know, doing something normal. I think she just missed a stair or something like that. And she came into my office and we worked on it for about 6 weeks, and she felt great. She could do a squat, she could go up and down stairs, she could walk for an hour or two, she could do everything that she wanted to do. And I said, okay, well, tell me what's going on. She's like, well, I'm going back to the surgeon, because she was sent from a surgeon. And I said, okay, well, are you guys going to talk about surgery? She's like, well, I don't really want surgery. My knee feels really good. And I said, well, but if you hadn't had that MRI, if you didn't know that your ACL was torn, would you be talking about surgery right now? She said, well, no. So, I mean, that information is interesting. It directs people maybe potentially into the wrong path, because a 45-year-old woman who doesn't do high level sports like tennis and basketball or pickleball or skiing or whatnot doesn't necessarily need an ACL to function properly, and could potentially have a bad outcome from a surgical intervention when she has a knee that is relatively pain free.
Yeah. I agree with you though. Insurance companies do not get anything right at all, period. And when that's why they, you know, anyways, I don't want to get into that argument. But however, on this case, I agree with you. I do believe that in my case, falling off that mountain, I couldn't even breathe. I mean, they needed to do an X-ray to like, hey, maybe you punctured lung. I mean, you got to do that. But in
Absolutely.
most cases, I believe that going to a physical therapist or doing something like that in lieu of, I don't want any more MRIs, right? I've had more than a lifetime full. I don't want any more CAT scans. I don't want any more. So if I can get away with going to physical therapy, someone like you who says, dude, here's your problem. Here's why this is that way, or this, the other thing, you one leg's longer than the other egg because you're so out of balance, and we get you straightened out or whatever the case. I think that's actually a pretty good idea that they do that first. I don't know. I mean, is six the proper number? Should it be three? Should it be four? I mean, how'd they come up with six?
That's an interesting question. How did they come up with six? I don't have a good answer for how they came up with six, but six is actually a decent number in the sense that if someone came in over a 3 week to 6 week time frame, and I was able to work on them and do the things that I do and give them some appropriate exercises, you should see a difference in 6 visits. It should either be getting better or worse. And if it's getting worse, then maybe it's time to get an image. And if that image shows something that is surgical in nature, then that might be a time where you want to go and take some action in that realm. But even if you know that you've had an ACL tear, you should still go to physical therapy pre-surgically, because you want that knee to move fully. You want that knee to actually heal up as much as it possibly can before surgery. You want that hip to move the way it should, and you want to get as much strength back as you possibly can pre-surgically, so that we can make you an excellent surgical candidate. Right. Again, I see lots and lots of people who have these shoulder surgeries and they never got their shoulder blade moving well, their upper back moving well, their collarbone moving well. And so then they come in, they have all this stiffness in that whole region, and I have to try to get that moving in the presence of this new surgery, right? And then I'm supposed to protect this new rotator cuff repair while I'm also getting the mid back and ribs and scapula and clavicle moving properly.
I when I had that accident and I fell off that cliff, I literally couldn't reach up to turn on my radio or the air conditioning in my car for 6 months. And for a
Mm,
year, I couldn't lift my arm over my head.
mm.
And so I didn't do
Should have come
physical
see me.
therapy. What's that?
You should have come see me.
I should have come see you. It would have been worth, it would have been better to frickin' fly up to fucking Washington and seen your ass than to be in pain like this. And the
Yeah.
worst, so then I go, I didn't have insurance, right? So I go to a doctor,
Hmm.
right? He goes, yeah, x-ray, bad, man. Your shoulder's really bad. You're going to need rotator cuff surgery. And I'm like,
Hmm.
I don't want rotator cuff surgery. I go, all right, well, let's try a cortisone shot. Nothing, right? No, I mean, zero effect at all. Didn't change
Hmm.
anything. So I'm like, all right, I'll schedule. So I met with a surgeon. He's like $2,800 cash because I don't have insurance. I'm going to pay you cash. He's like 2,800 bucks. I'm like, wow, that's really amazing. What a great deal. All right, that seems really inexpensive. He says, now you got to meet with the anesthesiologist. I'm like, cool. Anesthesiologist, like 8,000 bucks. Ooh, all right. Anesthesia. I contact, then they go, well, now you need a place to do it. So you got to contact an operation center. I go, all
Hmm.
right, give me a couple numbers. So I call $66,000. Dave,
Yep.
no bullshit.
Yep.
$66,000. I go, dude, can't you do it in my backyard? We'll set up the anesthesiologist. You'll cut me open in my backyard. What's the worst that can happen, bro? Six. So then I call him back. I go, you guys are out of your freaking mind. I'm renting a spot for 60. I said, I'll just rent a U-Haul or something. So they go, she comes, she goes, okay, well, good news. She comes back. She goes, we could do it for 40,000. I go, yeah.
That's good news.
That's good news. So,
Yeah.
needless to say, I did not get the rotator cuff surgery, and I'm super glad I did. It's worked. So, I went to a gal who's recommended by it, and she did the PRP.
Okay.
I did the PRP, and then I did some physical therapy,
Yeah.
and my arm's better. You know,
Yeah.
it's not anywhere near where it should be, and this was like from 6 years ago. I mean, this happened a long time ago. I'm now just getting, but I swear by the PRP and the
Hmm.
physical therapy.
Yeah.
Because the PRP, whatever that did, along with the physical therapy, just getting that movement going, forcing my body to move, which I couldn't do it on my own unless I, did that,
Yeah.
made all the difference. And I don't think surgery wouldn't have, because I don't think it was more than my rotator cuff, right? I mean, that was messed up in there.
Yeah. Obviously those cases it's hard to say. Um, but I mean, if you had gone and done surgery, then you would have gone and done a course of physical therapy post-surgically, and they would have gotten that shoulder moving, and they would have gotten the shoulder blade moving in your neck and all of those different things, and had you do a bunch of exercises. So your outcome probably would have been similar in nature.
But here's the
But
deal. The surgeon, no one recommended physical therapy before the
yeah,
surgery.
and that's crazy.
Nobody. They're just
Yeah,
like, dude, we've got you booked. I brought in the check to the anesthesiologist and the surgeon. I brought them in the check before I checked into the room because I thought, well, how much can a room be?
yeah,
Once I found out, they were really gracious. They just handed me my money right back because I had to cancel. But I mean, not one of them said, you need to do 6 months of physical therapy before the surgery
yeah.
because I'm so locked up. I mean, seriously, I mean, I couldn't pick up a coffee cup.
But I mean, so here's the problem too, is that everybody wants everything to be done yesterday, right? So a lot of times people they fall off the mountain and they injure their shoulder and they think, okay, I'm bound for surgery. I know I'm going to have this surgery. I'm just going to go have it now because I'm going to end up with it anyway. And it's like, well, that's not how this works, right? Obviously, we do some X-rays to rule out a major pathology, fracture, dislocation, that kind of stuff. But then we should slowly and gently get things moving, see how it all goes. And uh, a couple of months down the road, that's when we start talking about whether or not a surgery is necessary or not. And again, I come back to this ACL stuff. I mean, people just have this perception that because the NFL player tore his ACL and he's having ACL surgery tomorrow by the top doc, in the nation, that's exactly the care that they need and is best for them. It's like, well, that guy's getting that ACL surgery tomorrow because he wants to try to catch the last game of the season so that he can get his,
Bonus.
$20 million or whatever, right? Is
Yeah.
someone going to pay you $20 million for, the last 3 weeks of the year of work? Or like what are we talking about here? Um, it's it's so often the musculoskeletal care is being driven by the painful tissue. And I guess what I'm saying as a physical therapist, we need to stop just focusing on the thing that hurts, and we need to start focusing on how the whole system is moving and working and loading such that we can actually have real musculoskeletal health. Because again, all too often we're having maybe some procedures done, um, or again cortisone injections or whatever, and you're not getting the body moving properly, and it's just going to break down again, right? If you're not moving
Mhm.
properly and you're not loading properly, that's a recipe for having a problem in the future.
So I'm going to read this sentence to you, and you can walk me through it.
Okay.
Our job is to assess biomechanical dysfunction above and below the irritable tissue to allow for efficient mobility and dynamic loading tolerance. All right.
Okay, so let's give a simple example
Is
of
this
knee
when we
pain.
talk about beer and food?
I honestly, we have a lot of really good breweries in Spokane. Really good breweries in Spokane. But let me give you a very simple example of patellar tendonitis, right? You have this knee pain that is very, very common. People have trouble with either running or going up and down stairs.
I have
Okay.
that.
Okay.
I was a
So,
runner for years. Yeah.
so you have a hip problem, not a knee problem. Okay. What's probably going on there the vast majority of the time? If we think about what the knee does, the knee bends and it straightens. That's pretty much all it does, right? Especially when the knee is fully straight, it doesn't have the ability to rotate, and it doesn't have the ability to go side to side, right, in an abduction plane. So when we look at what the muscles around the knee do, again, the quadriceps straightens the knee, hamstrings bend the knee, right? They don't really have the ability to dynamically control side to side motion and rotational forces, right? So then when we look up the chain and down the chain, we look at an ankle that is supposed to move and rotate, right? And a bunch of muscles down there that do some work in the side to side and rotational planes. And then when we look up at the pelvis and the hip, that structure those structures also do a bunch of rotation and a bunch of side to side motion, and they load and control forces in all of those directions. So when you do, for instance, someone with patellofemoral pain or patellar tendonitis, if you ask them to do a squat, they will typically do a squat that has a lot of knee and not a lot of hip and pelvis movement to it. And so their knee will get sore when they do that squat. And if we can get the hip moving better and loading better, then all of a sudden their squat they move more through their hips and pelvis and less through their knee, and that force gets translated throughout the system more efficiently, right? So the patellar tendon is the painful structure, but it is not the problem. It is the result of the problem. The real problem is the lack of mobility at the lumbopelvic hip region and the lack of dynamic stability at those muscles that control the rotational and side to side forces that the knee doesn't have the ability to do. I mean, the knee just like kind of tries, is like, oh, I'll try to help out here by like doing this funky thing, but it just kind of gets beaten up. And
Dude, you're
we
gonna have to go upstairs for this one because the knee ain't just the knee, bro. Go to the
Yeah,
hip. Talk to the hip, man.
yeah, exactly, exactly.
So, what's the deal with meds now? How many people are like, I'm just gonna cure all my pain with meds. I don't need to go see a physical therapist because I'm just gonna opioid out.
Well, hopefully people are not getting as many opioids as they used to be, but uh, obviously, when I started roughly a billion years ago, it was not uncommon to have people on pretty high dose hydrocodone. I mean, they were taking 60 pills of hydrocodone fives every month, right? People were taking tons and
Wow.
tons of those medications, and you try to get them going on physical therapy, and they're like, "No, I'll just take a little bit more hydrocodone. That's fine." But honestly, the new hydrocodone is lumbar injections. They're cortisone injections in the lumbar spine. That's what I'm seeing now, where people, instead of doing something active and beneficial for themselves, they just want to lay on a table and they want something done to them. And
So wait a minute.
so,
So is that numbing the pain up the spine?
well, they're either doing injections into the facet, or they're doing it in oh God. Again, this is
It's
I'm
not.
not I'm
It doesn't sound like it's good either way.
well, and again, it's you're not fixing the problem. All you're trying to do is trying to deaden the spot that has more stress on it.
Is this almost like an epidural for someone
Yeah,
trying to have a
yeah,
baby?
epidural, yes. I mean, again, you can have an epidural, or you can have them into the facet. There's trigger point injections. There's all kinds of different kinds of injections that people are doing. But again,
That sounds like a really bad idea.
it's just a passive treatment, like just like what you're saying is like people want passive treatments, but the reality is that your body needs to be able to move properly and load properly, and that is the definition of musculoskeletal health, not pain free, right? If you want to just be pain free, then you should just go in one of those like salt tanks and just like float, right, and just do that all day every day, and you can be pain free because you're not moving at all. But
Right, right. But the challenge is
if you
what
want to
these
have
guys are doing is,
musculoskeletal health.
yeah, they're completely covering either with the meds, but especially with that other epidural shit. And then that thing's only gonna get worse. It's not gonna get better with the meds, right? So you go, dude, if you would have come to me a year ago instead of being all jacked up on this shit, now it's gonna be a lot more work, right?
Yeah, I mean, it certainly can be. I mean, I see people all the time who, again, their story is, yes, I've had 12 lumbar injections over the past 4 years, and it just isn't working at all anymore. It's like,
Yeah.
well, okay, now we're at a point where you have been stiff since the Clinton era, and it's coming home to roost, and you're trying to just delay actually moving better with injections, and you're not, again, injections can have a great purpose to help you tolerate getting through some physical therapy, right? If you start some physical therapy and things, and you're moving, and it's really getting aggravated, it's a nice thing to do, to go in there, boom, have a little bit of an injection to calm it down, so you can tolerate doing the exercises to get your body moving properly and loading properly. And again, the theory would be is if you are moving well and loading properly, then it shouldn't just get fired back up again. And again, that's typically what we see, because when I get done with somebody, I want to give them a program where they have the ability to keep themselves moving, and they have the ability to keep themselves strong, so I don't see them back, right? If I see somebody back for low back pain 3 months, 6 months after I just got done with them, then I'm kind of scratching my chin thinking like, okay, what did we get wrong? What didn't we do right here? This shouldn't be a case where you're just coming back every 3 to 6 months for the same exact thing. If I've gotten you moving well, and I've gotten you a program to keep yourself moving and strong, then we shouldn't just be doing a revolving door.
Yeah, and we're almost up on time, but that's what I was going to. What came to my head next was is physical therapy a maintenance program for people, or is it just get your ass healthy? Let me show you techniques for stretching and mobilizing the bones and body, whatever. And I don't want to see you again because I want you healthy. Or can physical therapy be a maintenance thing for old people like me?
I don't think there are definitely worse things you could do than go into your physical therapist every 6 months and say, hey, I'm a little stuck here. I'm a little stuck here. Can you get me moved a little bit? Can we work on my exercise program, or whatever? But everyone should have an exercise program. It doesn't matter what age you are. You should have an exercise program. That exercise program should have a combination of mobility, and it should have a combination of strength and dynamic stability and balance and coordination. All of those things should be incorporated with that. And it kind of doesn't, some of the dirty little secret is it doesn't actually matter what you do, right? You could do yoga, you could do Tai Chi, you could do Zumba classes, you could do, you should do some swimming and some step up aerobics and and lifting weights and whatever you want to do. It doesn't actually matter as long as you're doing a combination of things to get you both moving and strong and good balance. And there's going to be times, right? If you get in a car accident, yeah, you're going to need to go to the physical therapist. If you fall off a roof, yes, you're going to need to go to a physical therapist. Again, if you're not 20 years old, you're probably going to wake up sometime and you're going to be like, man, I got this, I have this weird thing, sure, maybe you get that worked out. But I also say if everybody did yoga from the age of 5, I probably wouldn't have a job. right? I mean, if everybody kept themselves moving and strong, then I wouldn't have a job at all. But I think I'm pretty safe in terms of job security.
When I was 5, I could do yoga. Nah, right now, I don't know, man. I don't know if I can do getting the squats. But you've been awesome with your time. I promise we'd get you out of here in a decent amount of time. So I only have
Yeah.
one last question,
Okay.
and I always ask this at the end of every podcast to everybody, and it doesn't matter. It could be about your physical therapy, about your life. It could be about anything you want. You can collect butterflies. I don't care. But I always ask people. If there's one thought that you would like to leave people with, a mantra, a thought, something that is near and dear to David Jeter, what would that last thought you'd like to sign off with for our guests?
Um, I guess my thought would be, I think people should think about musculoskeletal health and pain as musculoskeletal health is moving well, being strong, having good balance and coordination, and not just pain, right? Pain is a component of musculoskeletal health, but it's not the only metric of whether you are healthy or not. There's lots of people who are rolling around with not a lot of pain, but have a lot of stiffness, a lot of weakness, a lot of poor balance. And it's sort of a matter, there's sort of a ticking time bomb. And I feel like the people who are most healthy have a nice combination of movement, strength, and balance. And that's what musculoskeletal health is.
Awesome. All right. I love that. I love that. And we need to understand we need to eat right, we need to exercise, we need to take care of our structural health, our physical health. Um, but also we have to be able to tune into our body and know when we need to go see David Jeter to straighten our shit out. So you've been awesome. This is great. It flew by like I knew it would. I appreciate it very much. I mean, we don't have a book to pump or any of that stuff. Just you're a good dude trying to help people out, and I really appreciate that, man.
If you want to hear a couple of more of my sort of stories and anecdotes, I do have a Facebook page at Start with PT. So if you go to Facebook/Start with PT, that's a nice place to go if you want to just kind of learn a little bit more about some of my philosophy and some other specific anecdotes of different stories. Sometimes when I see patients or I'm talking to students and whatnot, I think, well, I should write this down somewhere, and that's just kind of a place that I write things down.
Awesome. All right, start with PT on Facebook. We'll put that on the podcast for sure, so people can go there and check you out and go, "Hey, he's a good guy. I trust him."
All right.
All right, man. Thank you so much. This was awesome. David Jeter, thank you guys. I can't wait for the next episode of What You Could. And everybody thank David Jeter. Thank you, man. Appreciate it.
All right. Thank you.
See ya. Okay, that was fun. That flew
Yeah.
by.
Yeah.
Yeah, you're awesome. That I learned a lot from that.
Thanks. Yeah, like I said, I just feel like sometimes it feels very Sisyphean in terms of pushing a rock up a hill uh, to try to get. I just see patient after patient after patient walking in, very much not knowing whether they should be in a physical therapist's office at their stage of the game or whether they should be doing something different. And it's like, nope, you're in the right place. You are where you should be. And if you're not in the right place, if we look at you and we do some things and we don't think that you should be here, we're going to send you elsewhere.
That's awesome. That's
Yeah.
awesome, man. Well, you're a blessing. You're helping a lot of people. I really appreciate it. Now you got time for your 1 o'clock.
Okay. Thanks a lot.
All right, thank you, David. Talk to you soon. Oh,
All right.
I'm gonna download this and email it to you. So I'll try to get
Okay.
this to you today. Do whatever you want with it.
Okay. Thank
All right,
you.
brothers. Thank you.
All
See
right.
ya.
Bye.
Thanks again for joining us on another episode of What If You Could podcast. Please subscribe, like, share, and give us any feedback. We'd love to hear it. And remember, if you can dream it, you can do it. See you next time.